Hello everyone, this is part 2 of my presentation about understanding retinoblastoma on the occasion of World Retinoblastoma Awareness Week. I am Dr. Sonal Yadav, practicing ophthalmic plastic surgeon and ocular oncologist from Pune. As for any other malignancies, the primary goal for treatment of retinoblastoma remains the life salvage, followed by eye salvage and vision salvage as secondary and tertiary goals. Treatment of retinoblastoma truly requires a multidisciplinary approach involving an ocular oncologist, a pediatric medical oncologist, a pediatric radiation oncologist, an ocular pathologist, a geneticist, and a social worker. The choice of treatment depends on the age at presentation of the child, tumor laterality, tumor location, staging, visual prognosis, systemic condition of the child, along with familial socioeconomic status and overall prognosis and cost effectiveness. The treatment modalities can be broadly classified into chemotherapy, which can be either intravenous or intraarterial, focal treatment modalities involving thermotherapy, laser, cryotherapy, periocular and intraocular chemotherapy, and plaque radiotherapy, and local modalities involving enucleation, exenteration, and external beam radiotherapy. Systemic chemotherapy with vincristine, etoposide, and carboplatin, called as a VEC protocol in standard or high-dose regimen as indicated, is still the primary modality of treatment in developing countries like ours. The indications for chemotherapy include bilateral retinoblastoma, where the chemoreduction can reduce the tumor volume to facilitate higher uptake of focal treatment. Advanced unilateral retinoblastoma to cause consolidation prior to surgery as a neoadjuvant therapy. High-dose chemotherapy is a very essential part of orbital retinoblastoma treatment protocol along with surgery and radiotherapy. Intraarterial chemotherapy is a newer modality of chemotherapy where the chemotherapeutic agents are given directly into the ophthalmic artery. The intraarterial chemotherapy protocol includes 1, 2, or 3 drug combination involving either topotecan, melphalan, or carboplatin. Intraarterial chemotherapy can be used as primary treatment modality as well as secondary treatment modality to treat recurrent or refractory tumors. Coming to intravitreal chemotherapy, management of vitreous seeds has been revolutionized with the help of intravitreal chemotherapy with either topotecan or melphalan or combination of both. Intravitreal topotecan serves better for Indian eyes with higher amount of pigmentation. This video demonstrates the safety enhanced technique for intravitreal injection in retinoblastoma eyes. Presence of diffuse vitreous seeds is indication for intravitreal chemotherapy. So here, after injecting the pre-calculated amount of drug, the needle track is then frozen with the help of a cryoprobe. Once the ice ball is formed, the needle is then slowly withdrawn in presence of the ice ball. This is to prevent the tumor egress from the needle entry site. 3 freeze-thaw cryocycles are then completed to the needle entry site. The eyeball is gently rocked to distribute the drug equally. And this completes the procedure for safety enhanced technique for intravitreal chemotherapy. Intravitreal topotecan works really well in causing regression of vitreous seeds as seen in these pictures. Periocular chemotherapy can be given along with systemic chemotherapy for patients with diffuse vitreous seeds. Can involve both carboplatin or topotecan. In focal treatments, transpupillary thermotherapy, which is provided with infrared radiation via a semiconductor diode laser of 810 nanometer. Modifications such as ICG enhanced TTT can also help treat tricky tumors. Chemoreduction and focal treatment with thermotherapy can give excellent tumor regression as seen here. Cryotherapy is another modality which is useful for tumors located anteriorly and are less than 4 mm in basal diameter. This video shows the ice ball covering the tumor. Cryotherapy can be repeated every 4 to 6 weekly till regression of the tumor. So the peripheral tumor can be well cared for along with chemoreduction and cryotherapy. Though maximum effort for eye salvage are always made, there are few indications which warrant primary enucleation. For example, unilateral advanced group D or group E tumor without any visual potential, unilateral advanced group E tumor with clinical risk factors such as diffuse anterior chamber seeding, total hyphema, extensive vitreous hemorrhage, anterior chamber or ciliary body infiltration, secondary neovascular glaucoma, or suspected scleral or choroidal or optic nerve invasion. A bilateral disease with one eye advanced tumor and negligible visual potential in the eye, and other eye with a small tumor amenable to focal therapy, and retinoblastoma in a thicical eye. While secondary enucleation is termed when the eye is enucleated after an effort of salvage has been made with the help of chemoreduction as well as focal therapy. For recurrent or refractory tumors, eyes with media opacity during or ongoing treatment, or secondary glaucoma due to tumor necrosis post chemotherapy or radiotherapy, or a thicical eye post chemoreduction. Enucleation also needs to be performed as a part of orbital retinoblastoma treatment protocol. These are few of the tips for enucleation, minimal manipulation enucleation in retinoblastoma. Make sure to minimally handle all the tissues respectively. Avoid perforation of the eye at any cost. Try and harvest a long, more than 50 millimeter long optic nerve stump to make sure you get negative resected margins. Then inspect the enucleated eye for macroscopic extraocular extension and optic nerve involvement. Harvest fresh tissue for genetic studies if applicable. Place a primary implant in the posterior tenon space. And avoid biointegrated implant if possible, if postoperative radiotherapy is necessary. Prolapse of the eyeball with the help of stay sutures and stumming of the optic nerve help getting a long optic nerve stump. Look for histopathological risk factors in the histopathology report, namely anterior chamber seeding, iris infiltration, ciliary body infiltration, massive choroidal infiltration, that is involvement of choroid for more than 3 mm, retrolaminar optic nerve invasion or invasion of optic nerve till the transaction, and scleral infiltration with extrascleral extension. The eyes which undergo enucleation can achieve excellent cosmetic outcome after custom ocular processes fitting, as shown in these images. The adjuvant therapy can either be only adjuvant chemotherapy or a combined adjuvant chemoradiation as per the indications. Radiotherapy in case of retinoblastoma can involve plaque brachytherapy or external beam radiotherapy. Plaque brachytherapy is indicated in recurrent or secondary tumors or refractory tumors. External beam radiotherapy is more often than not an adjuvant modality and as a protocol for orbital retinoblastoma. For orbital retinoblastoma, metastatic screening of the child followed by chemotherapy, surgery, and radiation is the protocol involved in treatment. For metastatic retinoblastoma, baseline investigations with metastatic screening, chemotherapy, intrathecal chemotherapy, autologous stem cell rescue, and palliative radiotherapy are the treatment offered. Thus, a stepwise systemic approach for diagnosis and a protocol-based approach for management of retinoblastoma surely improves the life salvage as well as eye salvage in these patients. This completes my presentation. Thank you for patient listening.